Shane's got a big old water bottle off to his side. Where's it? Bring that water bottle in. Let me see.
You haven't hear me clink it a few times to see, just so people
My man
know.
had this water bottle in one of the first podcasts he did, and every time he would put it down, it would sound like this. Just hit the table with it.
I don't want to make the editing too easy here.
Yeah, and I literally got to the point that I wouldn't even have to look at I wouldn't have to listen to it. I could just tell by the spike on the sound wave exactly when you were putting that dang water bottle back down. At least it's got the Foam for At logo on it, though.
I'm here for the team. See, you got to have the scan artist on there.
I know. So speaking of scan artists, we're going to be at Echo in what? A couple days. We're going to be in San Diego. Scan Diego is what we're calling it. We're going to be doing a cardiac ultrasound class, and Shane and I are going to be your fearless leaders for that class, and we're excited about it. You get in Sunday as well, right?
Yeah, and then I'm doing a lecture on antiemetics, so some nausea drugs, plus the pre-con with you.
Nice. Awesome, man. All right, let's get into some pain management stuff. So what is your goal when you have somebody who's in extreme pain? They look visually uncomfortable. What is your goal with pain management? Is it zero pain? Is it tolerable pain? Like, what are you asking the patient?
Yeah, so when I walk in the room, certainly getting your history of present illness and your story, and then I know it's controversial, but I still go by the numerical rating score saying, hey, how much pain are you on a scale of 0 to 10? 0 being no pain, 10 being the worst pain of your life. They'll give me a number, and then my goal is to work on treating that. And I usually try and target like around a 3. And certainly I'll never achieve that in some patients. And, mild comfort or mild improvement in their symptoms is what we end up getting. But often people don't consider the analgesia is a therapy that can reduce things like ischemia or heart rate in patients like aortic dissection. So everybody kind of considers analgesia the cherry on top after they've taken care of the important things, but it's absolutely life-saving for some of these critically ill people and can make movements tolerable and reduce things like PTSD from injuries and such. So I'll try to do the numerical rating score if it's possible and say, hey, how much pain are you in? And then kind of titrate that down and see if I can't work for that. Usually around a 3-0 if I can get to that point and I'm doing it in a safe fashion, but 3 is usually what I try to target.
Yeah, and I'm glad you said like 3, because there's no evidence to support that. That's literally Shane's mental model of what he aims for. 3, 2 is good, 1, 0 is nice. There was this thought process for a long time that you were masking the pain, and then it was going to be really difficult for the surgeon or the hospital, the ER, to be able to diagnose what is wrong with that patient. And so you had to keep them in pain. And specifically, you know what I'm talking about is abdominal pain. I'm sure you were taught, as well as I was, that in paramedic school, if you have a patient who has abdominal pain and then you give them something to mask that pain, then they're not going to be able to assess it. And at this point, we know that there's a lot of literature that shows that you actually have a better assessment because you can obtain an accurate history. You can figure out exactly what's going on, what they were doing when it started. Because you and I both know when you're in pain, that's at the forefront, right? Your cerebral cortex is telling you you're in pain. It's all I can think about. It's arousing. It's making you feel like it's all that can consume your thought process. And so, you've seen where you go in and you ask a patient, can you rate your pain on a scale from 0 to 10? And they're like, dude, it's horrible, right? Like, quit asking me to give it a number. And this may be a pain that they've never even experienced before, right? They may have never experienced chest pain like this. And then you're asking them to give it a number, and what we're really asking is, how bad is it? That way, when we ask later, we can see if it got better or if it got worse. And so my goal with pain management is to get the patient to a place to where they're comfortable. And it may not be 0 because we may be running up against hemodynamics. We may be running against respiratory rate, right? And there's some things that just are super painful, constantly stimulating that central nervous system. And it's difficult to try to pin them down and get them to say, 0 or 1. But if they can start recalling things that led up to it, if they look like they're breathing a little bit easier, if they look like their heart rate's coming down a little bit, and you can't always you can't always correlate like heart rate to pain. We get that. But then I start feeling better. Start feeling like at least I'm doing something to help myself obtain a history. It's almost like DSI, where a patient won't let you pre-oxygenate them or start an IV, and you go in and you give them some IV ketamine, and then you're able to do an assessment and you're able to get the vitals and get the IV. And so, it may not, like you said, it may not be 0, but it's a spot to where they're comfortable without that distraction. They don't have that like distracting, I don't want to say injury, but the distracting pain, really. And so when you are approaching a patient who is in pain, you're trying to get a head on it, you're trying to alleviate that pain, what is your go-to? Is it always paracetamol or the IV Tylenol first and then give an opioid on top of it? Is there any situations where you're jumping right to IV Tylenol? What's your model for that?
Yeah. So when I approach the patient, I'll say, hey, it looks like you're in some discomfort. I'd like to give you some medications to see if we can't work on improving that. And I'll very much ask the patient, hey, here are some options, because there are certainly patients who say, I have a history of opiate abuse. I don't want fentanyl, or I've had bad experiences with things like ketamine, and I don't want that. So I'll sit there and say, hey, here's my plan. So usually for moderate to severe pain, I'll target it either fentanyl or ketamine or some sort of combination, depending on the patient's history. The nice part with adding in or multimodal analgesia, so adding in different agents. So let's say you fall and break your leg, and we walk in, we're like, hey, this is obviously a pretty significant injury and obviously some pretty significant discomfort. Let's give you, a weight-based dose of fentanyl right now. And then I'm going to start some IV Tylenol along with that, because the fentanyl we know lasts usually around 45-ish minutes. So by the time you get the patient to the ambulance, and sometimes when we're moving them over at the hospital, the medication itself is wearing off, whereas the IV Tylenol takes usually around 15 minutes to kick in for kind of its peak analgesia, and it lasts several hours. So you kind of have that kicking around for a lot longer. So patients with the severe pain, I'll certainly add in multiple agents. So you may even do, like I'm going to give you an upfront dose of IV fentanyl, maybe some ketorolac, and I'm also going to do this Tylenol infusion in the background that'll hang for 10 or 15 minutes and let that go in. As long as they don't have contraindications to each of those agents or preferences to say like, I don't want any fentanyl. And we know that ketamine doesn't have addictive properties, so maybe I'm going to transition to that so that we can stay away from the opiates.
Yeah, it's interesting. So I got this book right here. I don't know if you can see this. It is the Guyton and Hall Medical Physiology book. I think I got it on like Amazon or something. And so when I was preparing for redoing the class on analgesia, I looked at, it was chapter 49, Somatic Sensations 2, Pain, Headache, and Thermal Sensations. And it was very, very interesting, to say the least, at some of the aspects of pain that I never even really thought about. Like, it describes 2 phases or 2 different pathways of pain. You have the fast pathway, which would be like, a bee sting, a pin pricking your finger, where you immediately like jerk back, right? And then you have the secondary pathway, the slower pathway, the aching, nauseating, throbbing type of pathway that is a little bit delayed, but it seems to intensify, right? It gets a little bit worse, and then it starts really bothering you. And that pathway, the second pathway, is really triggered by chemicals, things like bradykinin, things like potassium, things that happen when you damage tissue, and it's leaking into that area where those chemical pain sensors are, and you have mechanical pain sensors, and you have these free nerve endings. And so what I was reading is that prostaglandin, which is one of those inflammatory mediators that cause the pain receptors to increase in like their sensitivity, it makes them more sensitive. Those are the area where your NSAIDs work, like your Tylenol, your aspirin. They work not by directly blocking that, but by making the synthesis of that prostaglandin, by inhibiting that, so that way you don't have the sensitivity of those pain receptors. And so that seems like a good first step, right? Like if you have these receptors that are very sensitive, before you go in and try to like start blocking things within the central nervous system, to go ahead and try to get ahead on that prostaglandin that is causing those little receptors to be extremely sensitive. And that's exactly what paracetamol does, or that IV Tylenol. And so that seems to make a lot of sense to me. And, the fast pathway, the part that has like a super highway straight to the brain, usually uses like glutamate as its neurotransmitter because it's fast. That's where like ketamine works as well, by blocking those NMDA receptors. But glutamate is like that fast pathway. The slow pathway seems to, obviously it starts to build up. It seems to intensify. And when we are getting to the patient's bedside, it seems like we're mostly fighting against those chemical pain receptors that have leaking bradykinin and potassium and protons that are triggering those and actually stimulating them. And it was interesting. I was reading a study where there was no actual damage to the hand, but they injected just like bradykinin under the skin, and it was causing pain. And we've all seen patients that you're giving them potassium and they're like, oh God, it hurts, or calcium, and it's triggering like a pain response. And so giving the paracetamol seems to make a lot of sense. And it probably, if I'm guessing right, decreases the amount of actual opioids or synthetic opioids like fentanyl that you have to actually administer. So I wanted to ask you that as a follow-up is because you guys, how long have you had paracetamol? A couple years?
Yeah, I was gonna say probably a year and a half at this point.
So you've had experience with it, before it, and now with it. So I'm curious, would you say that you've reduced the amount of opioids, synthetic opioids that you're giving now that you're decreasing the sensitivity of those pain receptors?
Yeah, definitely. And I mean, at this point, it's 100% anecdote, or not 100%, but it's pretty significant anecdote because it's not something that we've studied at this point, but we're looking to do that just to see how much reduction we've had. But absolutely, especially we'll tell patients like, hey, because often when you tell people we're going to give you some Tylenol, they're like, my leg's hanging off here, guy. Like, you're giving me some Tylenol, my leg's hanging off here. And you're like, hey, you know what? When we combine this with other drugs and other agents, we give you several different classes of medications, we find that this is incredibly effective and lasts a long time. So building that up for the patients helps a ton. So we've absolutely noticed a reduction in the amount of things like fentanyl that we've given. And certainly we're adding in other things too. So I'd be remiss if I didn't mention, offering ice packs to patients and positioning and kind of the basics of analgesia help a ton, good splinting. But obviously there's patients who certainly need the medications themselves, and it's probably a pretty undertreated group in EMS as a whole.
Yeah, so let's talk about the logistics of actually administering it, because you said you were going to hang a bag of it. What is that? Is it so that's not a push medication? You're actually hanging it, letting it drip in over a certain amount of time, or are you putting it on an IV pump? Talk me through the logistics of like what that looks like.
Yeah, and one of the things I want to mention is cost too, because I do this class that talks about some different alternatives. Is one of the live classes for analgesia, and every time I'll bring up IV Tylenol, I'll be like, "How much do you guys think this costs?" And it'll be like $100, $1,000, and it's usually in the teens. So the pricing obviously going to vary. Yeah, it's going to vary depending on where you get it, but I think we pay around like 15 or 16 bucks per bag of IV Tylenol, which isn't bad at all considering.
No.
Certainly the pill form is a lot cheaper, but I do think there's a lot of advantage with having the IV form because a lot of our patients can't swallow very well. You have pediatric patients that you can certainly hit upon and give the agent to that maybe wouldn't take the PO Tylenol. As far as logistics go, it's a bag, 100 bag. They come in bottle form too, so you can get like a bottle of IV Tylenol. We'll hang up the bag, and they usually
You say 100 bag or 1,000?
100 bag.
100 milligrams or 100 mLs?
So it's 100. Sorry, that's a good point. It's 100 mLs, 1,000 milligrams, and 100 mLs.
Gotcha. Okay, gotcha.
So we'll give that dose for an adult patient. We'll give the 1,000 milligrams. The big concern with people is some sort of liver failure or acute liver injury. with IV Tylenol, but it's incredibly safe. The literature shows that it's super safe. Hospitals will still give these patients Tylenol. Depending on the facility, they may reduce the total overall Tylenol that they get in a single day, but it's incredibly safe. So you can even give it to undifferentiated intubated patients. So we'll hang the bag up of Tylenol. And we'll often do that first because you can even use that as it's certainly compatible with things like fentanyl. So you can use that as like your drive line as you're pushing other agents on allowing that to go in. We'll let it run over the 10 to 15 minutes and we'll let the patient know certainly that we're giving them the medication, but hey, this medication takes effect pretty quickly, usually 10 to 15 minutes. We might be giving you another drug, called fentanyl along with it, as long as that's okay with you. So that'll certainly take care of some of your acute pain needs and the things that are hurting you right now in the next 3 to 5 minutes. And then this Tylenol will last a lot longer than the fentanyl and can reduce the amount of fentanyl or other drugs that you get. So patients often are pretty comfortable with that.
Interesting. So, is there any weird effects? Do they have ringing in their ears or a weird taste in their mouth or anything that you've noticed when you're administering it?
Not really. It's certainly a good group of our patients were in the helicopter for, so sometimes they are not as will not state their symptoms as readily as we're bouncing down the road and can easily hear each other. But we've had, no adverse reactions to it, no problems with patients getting it who shouldn't. And our standards of care are pretty darn liberal when it comes to the Tylenol. So I think roughly around 40% of our patients get a dose of IV Tylenol at some point during their course. And we certainly report it once we get to the receiving facility so the patient doesn't get, the standard load of Tylenol that day if they get admitted. They can just kind of take that gram out. But certainly safe for pediatric patients as well. We just do the weight-based dosing, and we'll do that. So either if we have a pediatric patient, we'll usually, and it's a small patient, we'll usually draw it up into either run it in with a pump or draw it up into a syringe and just give it, over a very slow period of time. So you're still hitting that 10, 15-minute mark.
So we talked about the patient that has pain, they break something, some sort of musculoskeletal injury. But we also know like patients who are RSI will have pain as well. But it seems like you're more likely to push something that is central nervous acting. But do you think I just hit my mic. Do you think those patients would benefit from something like Tylenol, or like a paracetamol? Are you using it in those patients, or are you pretty much sticking to musculoskeletal type pain?
People often associate being intubated with the discomfort of having the endotracheal tube in, which is obviously really significant. But if I get into a car accident and you show up on scene and intubate me and I have, a femur fracture and my foot's angulated, like those things are still going to hurt a lot too. So adding in that option for analgesia, I think is fantastic, because if you're not targeting the irritation from the endotracheal tube, you're saying like, I think this is kind of low, a low amount of analgesia for the high incidence of discomfort and such for the endotracheal tube, you're still covering the patient's other pain needs. And certainly like we're using Tylenol for things like fever and, patients who...
Oh, you are?
Yep. So patients who, neuro patients who you need very tight control of their temperature and such, you can certainly provide them with IV Tylenol and have the same effects that you would if you gave it to your kid tonight for a fever. But I do think it does have an advantage in intubated patients. I would never use it as my sole analgesia plan, especially if somebody has neuromuscular blockade, like we just freshly gave them rocuronium. But there's not a lot of disadvantage with adding it in if there's, other factors that are really hurting them too.
Awesome. All right, we'll move off the paracetamol train and let's talk about IV ketamine for pain management, because you guys do that as well, correct?
Yep.
Yeah, so I was just in Kentucky and we were discussing, because I would say IV EMTs, but they're advanced EMTs can administer IV ketamine for pain control. And so we were talking about the logistics of delivering ketamine for pain management alone, right? So you're not trying to get those dissociative effects. You're just trying to control the pain. So you shouldn't see them going unresponsive or acting loopy or whatever. And so we were discussing how to do that, because the doses you're using are really small. You're talking like 25 milligrams, and these vials come in like 500 milligrams. And so one of the pitfalls, or one of the things I've seen, is you draw this up. You have a 1 cc syringe, and you're drawing up just a little bit, and then you push it, and it's like pretty much still in the extension set, and you'll see them push it real slow, and then they'll do this fast IV flush afterwards and negate the nice slow ketamine that they pushed. And we know like all the bad things that happen with ketamine happen when you push it too fast. That's where you get the laryngospasms, the hypersalivation, the apnea, the weird central nervous system effects of it. So what we were discussing, and what I think most people are doing, is similar to the paracetamol, is putting that in a 100 ml bag and letting that run in instead of sitting there trying to actually push it. And that's what I've done. Taken like 25 milligrams, put it in a bag, let it run in. If you have a pump, that's great. If you don't, you just want to let it run in, I think that's probably fine. I probably wouldn't even put this on the pump. It's a slow push, and my slow push is throwing it in a 100 ml bag and just letting it, trickle in. What are you doing? Are you doing something similar? How often are you actually using ketamine for pain management? And is that your model of how you would give it?
I've certainly fallen into, especially when we first got ketamine, I fell into the trap of putting into the, the 1 cc syringe and sitting there diligently pushing it slow, and then you push it fast, and the patient's like, holy crap. Even if it's a sub-dissociative analgesia you dose, they just hate it. I've had some adverse reactions as far as patients just despising it. So I think building it up and painting a nice picture for the patient helps a ton. So saying, hey, we're going to give you some ketamine for pain. And some people have notions on ketamine because they've heard of being used in nightclubs or whatever. But saying, hey, We're going to give you some ketamine for pain. And saying, hey, sometimes even when we give her really slow, it gives patients kind of a weird feeling. Some people feel numb all over the place or have a little bit of confusion. That's completely normal. But we always tell people, envision yourself on a beach, relaxed, laying in the sun. Because if you, tell people about purple elephants and then give them a quick dose of ketamine, that's probably what they're going to think about. But Same thing with mixing it into a 100 bag and then giving it over that few minutes, because pushing something that slow when there's, half an ml or whatever. But we try to do weight-based, 0.2, because once you get to 0.5 milligrams per kilogram, that's when you're very much into that danger zone of, either they're fully dissociated or partially dissociated, and now you're trying to figure out if you should give them a benzodiazepine to chill them out, or if you should fully dissociate them, and it's incredibly awkward. So we try to do that weight-based dosing, especially if you have the little old lady who's 50 kilos versus, the big tall dude who's 110. So that way you're kind of not in that middle ground for the little old lady. Same, we'll put that 100 bag.
I was talking to Dr. Ben Abo. Do you know him? He's got the luscious curly hair. He's always talking into a banana. Yeah. We were talking about how you dose this. And I think we had put a post up on Foam Frat the other day talking about the dosing regimens, right? The ketamine ladder to the moon. And like you go up the same way you come down, or I should say you come down the same way that you go up that ladder. And so you don't want to get to that dissociative phase, because then you got to go through the partially dissociative. But we were discussing the idea of what it is based off of as far as ideal body weight, actual body weight. And like, I got to tell you, like, I'll probably get some slack for this, but like, I think it should be based off of their actual body weight, or even like an adjusted body weight, because when you look at the lipophilicity profile of it, the distribution, if I have a 5-foot person who is a old lady, and then I have a 5-foot person who's 400 pounds, I feel like you're going to need more for that 400-pound person, just the volume of distribution and how that is going to get into the nervous system. It feels like you would have to somewhat take into effect their weight, their actual weight. And so we actually looked it up, and ChatGPT, we looked it up on ChatGPT, and it was like, ketamine should be based off of actual body weight, not ideal body weight. And then I found some other site that said ideal. I found another one that says actual. So for me, I probably go somewhere in the middle, right? I'm not going to completely say, 400 pounds, 200 and whatever kilos, I'm going to give this much ketamine. but I'm probably not doing it based off of their height. I'm probably taking somewhat of a consideration of how big they actually are, adipose tissue, lipid profiles, and then trying to base it off of that. What is your go-to? Are you basing that off of how tall they are?
Yeah, probably more of a middle ground, pretty similar to you. Certainly, we try to do things off ideal body weight, but we have those patients that just don't fit into that mental framework. So we will increase the dose. And the nice part is the ketamine onset's pretty quick. I mean, if you have only 100 bags, then you're kind of limited, but you can give them
Yeah.
that first dose and then say, you know what, we had a really good effect from this. We'll kind of hang out there, or we need a little bit more and keep adding in the agent because its effect is so quick that you often see the analgesia from it pretty rapidly.
Yeah, I totally agree. I feel like I'm more like based off of the temp makes sense because if they're in a low flow state, you grab their hand and it's cool, it's clammy, they're shunting all that blood to their core, they're shocky. The drugs that work on the central nervous system are not going to be hanging out in the extremities. You don't have the same volume of distribution. They're getting right to the central nervous system because that's where the body is shunting all the blood. And so you can see dissociative, or I should say partially dissociative effects around 25, 30 milligrams if you have a patient who is in a low flow state. If they're in shock and you're like, oh, let me just give you this for pain because ketamine is not going to drop your blood pressure or whatever, you definitely have to consider that the dose that you're giving is going to depend on the patient's hemodynamics as well.
You certainly don't want to, keep somebody in pain to maintain their hemodynamics, but I 100% agree that a lot of these patients need a titration down of whatever agent you're giving them for whatever their goal is. Because, you can certainly see hypotension from things like fentanyl that, causes a patholysis in somebody who's really relying upon that. Same thing with ketamine. And certainly as you relieve people's discomfort, you may see some changes in their hemodynamics, and just being aware of that potential, and that you may see it, especially if somebody is pretty tenuous.
All right, so moving out of ketamine, let's talk about Toradol. You have Toradol, you also have paracetamol. What's making you pick one versus the other?
Yeah, so certainly patients where we're concerned about bleeding, and I kind of say that with a caveat because if you go into the obstetrics world, especially patients who they're going to go in for a C-section, they almost always get a dose of Toradol. So these patients, you are 100% predicting they're going to bleed, they get a dose of Toradol. So I do think the effects of it are a little bit overstated. But I do get really cautious in people where I'm concerned about some sort of intracranial hemorrhage, or maybe like paraspinal bleeding or something where that could definitely worsen that, where you really want to be cautious about that. So I tend to shy away from patients like that. Extremes of age and renal failure are also other considerations. But I do think if you have somebody with a simple leg fracture, giving them a dose of ketorolac is totally appropriate. Certainly there's a risk that, if they were involved in an MVA, maybe they're bleeding into their gut or something. But patients who go to the operating room or immediately post-op get ketorolac all the time. So I think the hemorrhagic side effects from it are pretty overstated.
Do you think that we'll ever get to a spot to where EMS is doing nerve blocks with ultrasound? Even with
so there's
probably with ultrasound.
There's been a couple studies of in like 2010, 2012 of some places in the UK that were doing it. And anecdotally, I've seen some places that are doing it for blocks. I think as ultrasound becomes more prevalent in the pre-hospital setting, it would definitely have some advantages, especially that you can drastically reduce the amount of drugs that you're giving people. But you also have to take into account that it takes a little while to do it, and you're on scene for that period of time, because I can't imagine bouncing down the road and trying to do something like that. And are we making the best use of our time with somebody who has an angulated leg fracture that maybe has other extra injuries somewhere else too? So it would be cool. I'd be a fan.
Before we close out, I gotta tell you this because I thought this was super, super interesting. This is my book, Guyton Hall, the Arthur Guyton book. Listen to this. So you know how patients will have like referred pain. So they'll be having ischemic chest pain, but then they'll develop like this shoulder pain, right? Or like their neck will hurt as well. Like somebody's having an MI. Oh, my neck, my jaw hurts. My shoulder hurts. Listen to this. I thought this was interesting. It says When visceral pain is referred to the surface of the body, the person generally localizes it in the dermatomal segment from which the visceral organ originated in the embryo, not necessarily where it is now. For example,
That's so cool.
the heart originated in the neck and upper thorax, so the heart's visceral pain fibers pass sympathetic sensory nerves and enter the spinal cord in T5. And then it goes on to like stomach pain, and like where it develops in the embryo is where those nerve fibers start to connect. And so because the heart develops like in the throat here, in the neck, that's why they get shoulder pain and neck pain, and it's all up here. So I wanted to close this out with that because I'm like, you know what? I never knew that. And I don't see any citations for it, but that's cool as hell, man. So I'm going to go with it.
That's really cool.
Awesome, man. Shane, thanks so much for coming on the podcast, dude. You do a great job. If you guys haven't checked out Shane's classes inside studio, definitely do that. He does live classes. He's got some recorded classes. And if you're going to be at Echo, come by the Foam Frat booth. Come say hi. Come hang out with Shane and I at the ultrasound course. And yeah, we'll see you later. Thanks for coming on, Shane.
Hey, man. Thank you.